Hello everyone, I am Fatima Kabi, a radiation oncology chief resident at King Fahad Specialist Hospital, Dammam in Saudi Arabia. Today, I'm going to discuss Oropharyngeal Squamous Cell Carcinoma, or OPSCC, a type of head and neck cancer. OPSCC originates in the oropharynx region, which includes the base of the tongue, the soft palate, the tonsils, the posterior pharyngeal wall, and the lateral pharyngeal walls. It develops from the squamous cells that line these surfaces. Historically, OPSCC was primarily linked to tobacco and alcohol use. These risk factors remain significant contributors to the disease. However, in recent decades, there has been a dramatic shift in the epidemiology of OPSCC. A new player has emerged on the scene, the human papillomavirus, or HPV. HPV is a common sexually transmitted infection. Certain high-risk strains of HPV, particularly HPV-16, are now recognized as a major cause of OPSCC. The rise of HPV-associated OPSCC has important implications for the understanding, diagnosis, treatment, and prognosis of this disease. This video will delve into the complexities of OPSCC, exploring the distinctions between HPV-positive and HPV-negative disease. It will also discuss the latest advancements in staging, management, and treatment strategies for this increasingly prevalent cancer. The identification of HPV as a causative agent for OPSCC has revolutionized our understanding of this disease. It is crucial to recognize that HPV-positive and HPV-negative OPSCC represent distinct entities with different risk factors, clinical presentations, and treatment responses. HPV-negative OPSCC is the traditional form of the disease. It is strongly associated with long-term tobacco and alcohol use. These substances contain carcinogens that damage the DNA of cells lining the oropharynx, leading to uncontrolled cell growth and tumor formation. Patients with HPV-negative OPSCC tend to be older and have a history of heavy smoking and drinking. In contrast, HPV-positive OPSCC is driven by infection with high-risk HPV types, primarily HPV-16. These viruses integrate their DNA into the host cell genome, disrupting normal cellular processes and promoting cancer development. HPV-positive OPSCC is more common in younger individuals with fewer traditional risk factors. They may have a history of multiple sexual partners but may not be smokers. These distinct etiologies result in significant biological differences. HPV-positive tumors often exhibit a more robust response to treatment. They have a better prognosis compared to their HPV-negative counterparts. However, the rise of HPV-positive OPSCC has led to an increase in the overall incidence of the disease, particularly among younger individuals. Understanding these fundamental differences is crucial for tailoring treatment strategies and improving outcomes for all patients with OPSCC. Accurate staging is crucial in managing OPSCC. It helps clinicians evaluate the disease's extent, predict outcomes, and guide treatment plans. The TNM system is used for staging OPSCC, developed by the American Joint Committee on Cancer, or AJCC. The TNM system assesses three main factors: tumor, or T. This describes the size and extent of the primary tumor in the oropharynx. Nodes, or N. This evaluates the involvement of neck lymph nodes. Metastasis, or M. This indicates if the cancer has spread to distant sites. Based on these factors, OPSCC is staged from 1, early stage, to 4, advanced stage. Higher stages signify more extensive disease and a poorer prognosis. The TNM system provides a standardized staging framework, but HPV-positive and HPV-negative OPSCC often show different tumor spread and lymph node involvement patterns. For example, HPV-positive OPSCC is more likely to have lymph node metastases at diagnosis, even with smaller primary tumors. This reflects the unique biological behavior of HPV-driven tumors. Thus, incorporating HPV status into staging systems is an active research area. The goal is to create more accurate prognostic tools for personalized treatment approaches for OPSCC patients. Locoregionally advanced OPSCC refers to cancers that have spread beyond the primary tumor site in the oropharynx to involve adjacent structures or lymph nodes in the neck. These tumors present a significant therapeutic challenge. They are linked with a higher risk of recurrence and mortality. Several factors contribute to the aggressive nature of locoregionally advanced OPSCC. Firstly, the anatomy of the head and neck region is intricate. It contains essential structures such as blood vessels, nerves, and muscles. Tumors in this area can easily invade these structures, complicating surgical removal. Secondly, the rich lymphatic drainage of the head and neck allows cancer cells to spread readily to lymph nodes. This can lead to the development of occult metastases, which are not detectable on clinical examination. Lastly, locoregionally advanced OPSCC is often associated with a high tumor burden and the presence of risk factors. These include smoking, alcohol use, and poor nutritional status, which can compromise treatment response and overall survival. Managing locoregionally advanced OPSCC requires a multidisciplinary approach. It involves a combination of surgery, radiation therapy, and chemotherapy. The goal is to achieve local control of the disease while minimizing treatment-related side effects and preserving quality of life. Section 6. Criteria and Considerations. In recent years, there has been increasing interest in non-surgical approaches for the management of OPSCC, particularly for HPV-positive tumors. This shift is driven by several factors, including the excellent response rates observed with chemoradiation therapy in this patient population and the desire to minimize treatment-related morbidity. Non-surgical approaches typically involve definitive chemoradiation therapy. It combines radiation therapy with concurrent chemotherapy, often using cisplatin as a radiosensitizer. Cisplatin enhances the effects of radiation by damaging the DNA of cancer cells and making them more susceptible to radiation-induced cell death. The criteria for selecting non-surgical approaches over surgery are complex and depend on several factors, including the stage of the disease, HPV status, patient preference, and the expertise of the treating team. Generally, patients with early-stage HPV-positive OPSCC who have favorable tumor characteristics, such as small tumor size and no evidence of spread to lymph nodes, may be candidates for non-surgical treatment. However, it is crucial to note that non-surgical approaches are not without their own set of potential side effects. These include acute toxicities such as mucositis, dysphagia, and skin reactions, as well as long-term complications such as xerostomia, dysgeusia, and hypothyroidism. The decision of whether to pursue surgery or non-surgical treatment for OPSCC is a complex one that should be made on a case-by-case basis through a shared decision-making process between the patient and the treating team. Managing the neck is vital in OPSCC treatment. Lymph nodes are frequent metastasis sites, even in early-stage disease. Lymph node involvement affects prognosis and treatment planning. For CN0 patients, elective neck dissection or radiation is standard practice. This involves removing high-risk lymph nodes to prevent cancer spread. For CN+ patients, a more extensive neck dissection is necessary. SLNB is a minimally invasive procedure to identify the sentinel lymph node. If negative, extensive dissection may be avoided. Further research is essential. HPV-positive OPSCC tailoring treatment for a distinct subtype. As previously discussed, HPV-positive OPSCC represents a distinct subtype of the disease with unique clinical behavior and treatment considerations. Patients with HPV-positive OPSCC tend to be younger, healthier, and have fewer comorbidities compared to their HPV-negative counterparts. They also exhibit a more robust response to treatment, with higher rates of complete response and improved survival outcomes. Given these favorable prognostic factors, there has been a growing movement towards treatment de-escalation in HPV-positive OPSCC. The goal of treatment de-escalation is to reduce the intensity of treatment while maintaining excellent oncologic outcomes and minimizing treatment-related side effects. Several strategies for treatment de-escalation in HPV-positive OPSCC are currently being investigated in clinical trials. These include reducing the dose of radiation therapy, using alternative chemotherapy regimens, and exploring the role of surgery alone in select patients with early-stage disease. Early results from these trials are promising, suggesting that treatment de-escalation strategies may be feasible and effective for many patients with HPV-positive OPSCC. However, it is important to note that these strategies are still investigational and should only be implemented within the context of a clinical trial. Future directions and conclusion. Advancing the fight against OPSCC. Significant strides have been made in the understanding, diagnosis, and treatment of OPSCC in recent years. The identification of HPV as a causative agent for a subset of OPSCC has transformed our understanding of the disease and led to the development of more targeted and effective treatment strategies. Despite these advances, OPSCC remains a significant health challenge, and further research is essential to improve outcomes for all patients. Future directions in OPSCC research include developing more accurate biomarkers to predict treatment response and prognosis, identifying novel therapeutic targets for both HPV-positive and HPV-negative OPSCC, optimizing treatment de-escalation strategies for HPV-positive OPSCC, improving supportive care measures to manage treatment-related side effects, and developing effective strategies for the prevention of OPSCC, including HPV vaccination. The management of OPSCC requires a multidisciplinary approach with close collaboration among head and neck surgeons, radiation oncologists, medical oncologists, speech-language pathologists, dentists, and other healthcare professionals. By working together and continuing to advance our understanding of this complex disease, we can strive to improve outcomes and quality of life for all patients with OPSCC.